Greetings students and welcome back to Nephroma. In this lesson I'm going to solely focus on interpretation of acid-base disorders based on blood gas and electrolyte analysis. I won't be covering differential diagnoses, I won't be covering physiology or pathophysiology or management. I'm only going to focus on interpretation, and I'll start out by going on the blackboard. You can break down acid-base interpretation into 6 simple steps. But before we get to those steps, there's a short preamble I'd like to go over about normal values. So for the purposes of acid-base interpretation, normal or standard values on arterial blood gas include a pH of 7.4, a PCO2 of 40, a bicarb of 24, and an anion gap somewhere between 8 and 12. Of course, keep in mind that the normal value for the anion gap depends on your albumin, such that for every change in the albumin by 1 gram per deciliter, the anion gap should drop by 2.5 approximately. This is because albumin, which is negatively charged, is a major contributor to the anion gap. So if the albumin is lower than normal of 4 or 40 grams per liter, then the anion gap naturally should drop relative to the standard of 8 to 12. So let's now go through the steps of acid-base interpretation, starting with step 1, which is to look at the pH to determine whether there is an acidemia, i.e. a pH less than 7.4, or an alkalemia, i.e. a pH greater than 7.4. If you have an acidemia, the primary acid-base disturbance is an acidosis. If you have an alkalemia, the primary acid-base disturbance is an alkalosis. Keep in mind that acidemia and alkalemia are different from acidosis and alkalosis. Acidemia and alkalemia exclusively refer to blood pH and its relation to the magic number of 7.4. Acidosis is a process which leads to acidemia, while alkalosis is a process which leads to alkalemia. So even if you have an acidosis going on, you could still be alkalemic if there are other alkalosis processes occurring. So with step 1, you figured out whether your primary disturbance is an acidosis or alkalosis. The next step is to look at the PCO2. If the PCO2 changes in the same direction as the pH, the primary disturbance is a metabolic one. If the PCO2 changes in the opposite direction, the primary disturbance is a respiratory one. And that leads to step 3, which is to determine whether there is adequate compensation for the primary acid-base disturbance you've discovered. Keep in mind that especially for metabolic processes, there is respiratory compensation, and that for respiratory processes, there is metabolic compensation. In general, for metabolic processes, the compensation is not enough to normalize pH. For respiratory processes, especially when given enough time, on the other hand, the metabolic compensation can sometimes normalize the pH. So that leads to the question, what is considered adequate compensation? Well, for metabolic processes, adequate respiratory compensation occurs pretty instantaneously. So there's only one compensation formula for metabolic acidosis and metabolic alkalosis involving the PCO2. However, for respiratory processes, the kidney usually takes time to compensate. So the compensation for each primary respiratory process can be calculated in acute terms and in chronic terms. For a metabolic acidosis, you can calculate respiratory compensation using Winter's formula. So your PCO2 should be 1.5 times the bicarb plus 8. There's also a plus minus of 2 here, so as long as your CO2 is within this margin of error, even if it's not exactly 1.5 bicarb plus 8, you still have appropriate compensation. What about for metabolic alkalosis? Well, in metabolic alkalosis, your PCO2 should rise since you would hypoventilate in order to compensate for the extra base that's floating around. In this case, for every 10-point rise in bicarb, your PCO2 should rise by 7 points from the standard 40, so a correction factor of 0.7. Of course, you could package this into a neat formula that looks something like this, bearing in mind that there is a plus minus of 3 over here. Now, for respiratory acidosis, acute metabolic compensation is quite minimal. So for every 10 rise in your PCO2, your bicarb should rise by 1 from the standard 24, with a plus minus of 2. For chronic respiratory acidosis, your compensation is such that for every 10 rise in your PCO2, your bicarb should rise by 3.5, again with a plus minus of 2. I've written the 2 formulas here to express this in case you prefer formulas over verbal statements. Now for respiratory alkalosis, acute metabolic compensation is again quite minimal. For every 10 fall in your PCO2, your bicarb should drop by 2 with a plus minus of 2. And for chronic respiratory alkalosis, your compensation is such that for every 10 fall in your PCO2 from the standard of 40, your bicarb should drop by about 5, again with a plus minus of 2. I've written again the two formulas here to express this in case you prefer those over verbal statements. Keep in mind, though, that different sources give you slightly different formulas for acute and chronic respiratory compensation. Some use a factor of 0.4 as opposed to 0.35 for chronic respiratory acidosis. Some use a factor of 0.4 as opposed to 0.5 for chronic respiratory alkalosis. In general, though, these formulas that I mentioned should get the job done both on board exams and in the clinical setting. Arguing over whether it's 0.4 as opposed to 0.35 is probably not super clinically important and really just bickering at that point. So now you've determined what the PCO2 or the bicarb need to be for appropriate compensation. If there is appropriate compensation within the plus-minus margin of error that I've given, you're done with step 4 and can proceed to step 5. However, if there's an inappropriate compensation, then that means there's an additional acid-base disturbance going on, which you can then determine. In the situation of an inappropriate metabolic compensation, if your bicarb is higher than expected from that compensation, you've got a metabolic alkalosis going on. If the bicarb is lower than expected, you've got a metabolic acidosis going on. Similarly, in the situation of inappropriate respiratory compensation, if your PCO2 is higher than expected from what it should be if it were fully appropriately compensated, you've got an additional respiratory acidosis happening. If your PCO2, on the other hand, is lower than expected, you've got an additional respiratory alkalosis happening. So now you've determined the compensation for your primary acid-base disturbance and whether or not there's a secondary disturbance going on. The fifth step is to check the anion gap. If the gap is normal and you've taken your albumin into account, you're done. If the gap is elevated, however, then you've got to go to step 6. And step 6 is to determine the delta-delta ratio. The delta-delta ratio really just means the ratio between the change in the anion gap from a standard of 12, or whatever the anion gap should be depending on your albumin, to the change in bicarb from the standard of 24. Ideally, if you just have an elevated anion gap metabolic acidosis, the change in anion gap should exactly equal the change in bicarb. So if the ratio is 1, then you've just got a simple HAGMA, a high anion gap metabolic acidosis. If the ratio is less than 1, particularly if it's less than 0.8, then the fall in your bicarb is more than the change in your anion gap. That means there's another metabolic acidosis process going on that's causing your bicarb to fall further than otherwise predicted by your anion gap, which means that in addition to the high anion gap metabolic acidosis, you've got a metabolic acidosis with a normal anion gap, or a NAGMA. On the other hand, if the ratio is greater than 2, then the change in your anion gap is significantly greater than the fall in the bicarb. This means that there's another process going on that's causing the bicarb to rise, such as a metabolic alkalosis, or rarely from compensation for a chronic respiratory acidosis. Now, when your ratio is between 1 and 2, that's a bit of an ambiguous area. You could consider metabolic alkalosis being superimposed on a HAGMA in this range, but you could also just have a simple HAGMA in certain cases, particularly with lactic acidosis, where you can have a delta-delta ratio of 1.6. The reason for this is that even though the anion, the lactate, contributes to the anion gap, it actually gets buffered by things other than bicarb, which means that the drop in bicarb for a lactic acidosis will actually be less than the change in the anion gap. In general, that works out to a ratio of 1.6. So now we've covered the 6 steps for acid-base interpretation. I'm going to now solve an example problem that shows you how to apply these steps and put them together in a clinical setting. Say I have a 70-year-old male patient with a history of coronary artery disease who presents with altered mental status and a few days of vomiting. Arterial blood gas shows the following values, and an electrolyte panel looks something like this with an albumin of 3. The question here is, what acid-base disturbances are happening with this patient? So let's go through this step by step. The first step is to look at the pH, which is 7.46 and indicates alkalemia. So our primary disturbance is an alkalosis. The next step is to look at the PCO2, which is decreased relative to the standard of 40. So the PCO2 has decreased while the pH has increased. And since they've changed in opposite directions, this means the primary disorder is a respiratory disorder. Combining this with what we found from step 1, that means the primary disturbance is a respiratory alkalosis. The third step is to evaluate compensation. So for a respiratory alkalosis, since there's a drop of roughly 20 in the PCO2 in this patient, the drop in bicarb should be 4 for acute compensation or 10 for chronic compensation. So that means the bicarb should either be 20 or 14, depending on whether this is acute or chronic. Now, the patient's actual bicarb here is 20, so if this were an acute process, we have appropriate compensation, but if this were a chronic process, we actually have inappropriate compensation. The problem is that it's very hard to know from the one-line story I've given you whether the underlying process is acute or chronic. The patient's been having symptoms for a few days, which is generally how long it takes for chronic compensation to occur, but I don't know if the respiratory stuff started before that or after that. So we can't really use step 4 to determine appropriateness of the compensation if we don't know whether we're compensating for an acute process or a chronic process. So we'll actually have to skip step 4 here and go straight to step 5, which is where we would calculate the anion gap. In this case, the anion gap is the sodium minus the chloride minus the bicarb, so 140 minus 100 minus 20, which should give you a gap of 20. And since you have an elevated anion gap, you've got to move to step 6, which is to find the delta-delta ratio. In this case, the change in anion gap would be 20 minus the standard anion gap for this patient, divided by 24 minus the patient's bicarb of 20. Now, the standard anion gap for this patient is actually 9.5. The reason for this is that the patient's albumin is only 3, which is a drop of 1 from the standard of 4 grams per deciliter. In this case, since the albumin drop is 1, the standard anion gap should then drop from 12 to 9.5, since there's a drop of 2.5 in the standard anion gap for every 1 point drop in albumin. I went over this rule at the start of the video right up here. This means that the delta-delta ratio is 10.5 divided by 4, which is obviously greater than 2. So this means that you must have a metabolic alkalosis on top of your hagma as an additional acid-base disorder. So in the end, the patient has a respiratory alkalosis, an elevated anion gap metabolic acidosis, and a metabolic alkalosis. So 3 acid-base disorders in one. These questions with triple acid-base disorders can sometimes show up on board exams for internal medicine residency. I generally wouldn't expect a med student to diagnose 3 simultaneous acid-base disorders, but I would expect this from a resident. There's also a couple of other pearls with this example problem that I'd like you to take away. One pearl is that for a lot of clinical scenarios, not all 6 of these steps will necessarily apply. So for example, you saw how I had to skip step 4 in this problem because I couldn't tell if this were an acute or chronic respiratory process. In situations where you might have to skip steps, it's really important to follow through completely and do everything, including calculating the anion gap and delta-delta ratio. You can't just stop at step 4 and call it quits. If I did that here and said this was an acute respiratory alkalosis with appropriate metabolic compensation, I would have missed 2 additional acid-base disorders. Now, for those curious as to why this patient had 3 acid-base disorders, I'll tell you what happened. He was on aspirin for coronary artery disease, overdosed on it, and vomited for a few days. Recall that aspirin overdose can give you a hagma and a respiratory alkalosis, so 2 separate disorders. And since the patient was also vomiting afterwards, he had a metabolic alkalosis from losing chloride in his vomiting. So that's how he got 3 different acid-base disorders. Anyway, that should do it for this video. Thanks for watching.